Hi, my name is Wesley Green. I'm a third-year Doctor of Occupational Therapy student at the University of the Pacific, and I would like to welcome you to the first lecture in this three-part video lecture series focusing on post-stroke fatigue. The goal of this lecture series is to provide deeper insights into the neural mechanisms and neuroscience that underlie post-stroke fatigue, and discuss how we can better align our evaluation and treatment methods based on these underlying mechanisms. We'll get started in this first lecture titled Reframing Post-Stroke Fatigue, Translating Neuroscience to Occupational Performance Deficits, where we will take a look at how occupational therapy and rehabilitation is currently viewing post-stroke fatigue before we look at the current neurophysiology and the neuroscience behind it, and discussing how this presents into occupational performance deficits. To start off this lecture, I'd like to go over the learning objectives for both the webinar series as a whole and this initial lecture. For the webinar series, we're looking to characterize post-stroke fatigue presentations to improve clarity in complex clinical cases, synthesize contributing factors with observed performance patterns to organize and focus evaluation, and determine assessment and intervention priorities using a structured framework to support efficient clinical decision-making. And these are the objectives we will target through lectures 1, 2, and 3. For this lecture 1, look to explain the key neurophysiological mechanisms contributing to post-stroke fatigue, analyze post-stroke fatigue as a systems-level condition by linking the neural network dysfunction with altered effort perception and energy regulation, determine the impact of post-stroke fatigue-regulated mechanisms on occupational performance across domains, and describe post-stroke fatigue presentations in a patient case using a neural efficiency lens. Just a quick breakdown and roadmap of how this lecture will go today. We'll begin with discussing what post-stroke fatigue is, its definition, its prevalence, its presentations of impact, go into discussing the current approaches to evaluation and treatment for post-stroke fatigue within occupational therapy, dive into the current neurophysiology before moving into the emerging neuroscience, taking that understanding of that neurophysiology and neuroscience and translating it into performance deficits before we close things up and get ready for the second lecture. So to begin, I'd like to present you with a case scenario. A patient with a typical presentation of post-stroke fatigue. So this is Marcus, 47-year-old male, 8 months post-left MCA stroke, independent with all ADLs with minimal observable motor impairments. He reports a persistent, unpredictable fatigue that's not always tied to his exertion, and significant difficulty with cognitive task and multitasking. Reports a limited return to work due to an early crash and reduced tolerance for sustained activity. So this is kind of that typical presentation of post-stroke fatigue. They seem pretty fine on the outside. They have a little minimal or limited impairment. They live independent or modified independence, but they simply have difficulty coming back to regular performance in daily tasks. To begin, we'll discuss with what post-stroke fatigue is. Post-stroke fatigue has been defined in the literature as an overwhelming sense of exhaustion, dread, or lethargy with physical, emotional, cognitive, and perceptual contributors. These are not relieved by rest and significantly impair daily functioning. They're often described as persistent, disproportionate fatigue not explained by exertion alone, and it occurs across the continuity of care from the acute well into the chronic phases. It's distinct from deconditioning, depression, and sleep disturbance, so it is very hard to differentiate the cause of this fatigue from others. It impacts a large percentage of stroke survivors, anywhere from 30 to 70%, with 3 out of every 4 survivors likely to experience post-stroke fatigue at some point in their life post-stroke. There's an increased correlation of prevalence with the female gender, following ischemic strokes, MCA strokes, and posterior circulation strokes. Some clinical significance, it's associated with significant reductions in motor and cognitive performance, reduced rehab outcomes, impaired quality of life, low return to work rates, and decreases in social participation. At the same time, it's associated with an increase in depression and depressive symptoms, and an increased risk of self-isolation. While post-stroke fatigue is difficult to differentiate from other sources of fatigue, it does have some of its own key indicators, and some like we have on these clinical key points here. Post-stroke fatigue is often disproportionate to observable impairment. So the severity of the stroke is not associated or is not correlated with the severity of post-stroke fatigue. For example, if you had a patient who experienced a TIA, and a patient who had a significant posterior circulation stroke who was in the acute care or in the hospital for a couple of weeks, the fatigue they report is not going to be equal. The TIA might experience a significant amount of fatigue, while what would be considered a more significant stroke isn't reporting that level of fatigue. Its presentation is fluctuating throughout the day. It's very context dependent. It's not consistently related to physical exertion, so light, basic, simple, everyday, sometimes what used to be automatic tasks start taking the energy out of these patients quickly. Again, it's difficult to differentiate from psychosocial challenges and other sources of fatigue or amotivation. Patients also often describe an increased effort for routine tasks, a reduced tolerance for multitasking, and a need to withdraw despite preserved ability or despite feeling like they have the physical capacities or the energy to to complete a task. So now that we've defined and described post-stroke fatigue, we'll now take a turn and look into how occupational therapy is currently approaching post-stroke fatigue. So at current in occupational therapy, post-stroke fatigue is addressed largely in the same ways that we address all fatigue, which is one of the biggest barriers and the biggest gaps in its treatment thus far. So largely starting with that symptom and energy management. This is our energy conservation techniques, the prioritization, pacing, planning, those scheduled rest breaks, and modifying the activity. Incorporated with concomitantly at the same time the impairment-focused approaches, endurance training, strength training, task-specific functional practice, building them the building blocks to get back to living independently, or what level of independence we can get them to post-stroke, whatever level of performance that can be, while also addressing those psychosocial and behavioral factors. We do have a biopsychosocial approach. We have that person-first approach, which is great. We talk about education on fatigue, sleep hygiene, using those cognitive behavioral strategies so they can really understand their fatigue triggers and how their day is going, so they can best prioritize and plan what's going on. Our main focuses are modifying the activity and managing fatigue symptoms. So moving on now, let's consider some of the strengths and just considerations of these approaches that we have for post-stroke fatigue in general. So some of the strengths to start out with, it is grounded in evidence for fatigue specifically. This is how we treat fatigue, and we know that this helps treat most fatigues. These approaches that we're taking, we emphasize independence, occupational engagement, self-management, and autonomy. We give them the tools so they can get back to the level of independence or as close to it as they can after the stroke. We support participation, activity tolerance, and strategy development and carryover. We really focus on giving them the skills and the knowledge and capacity to manage these fatigue symptoms so they can best live their lives. Things to consider though is that PSF presentations differ from other fatigue conditions. Post-stroke fatigue is not consistently related to physical exertion. It is heavily influenced by cognitive and environmental task demands over the physical exertions that these tasks usually take, and it fluctuates across context and time. And one of the main things is that it does not improve with rest. And with our energy modification strategies, our including those rest breaks, everything that we do currently for fatigue banks on the concept that rest or reduction restores energy. And with post-stroke fatigue, that simply doesn't happen. So what we see as a result of our treatment is that some of the management approaches and treatment approaches that we take work and some of them don't. And it differs from patient to patient, which typically happens with occupational therapy anyway, with how individualized it is. But post-stroke fatigue is a specific thing. Its presentation in each patient is different because each patient is different, but at its core, it is the same. Post-stroke fatigue, I mean. And then again, alignment with fatigue experiences may be variable. Because each person is going to be different, we don't know which ways are working the best, and because it fluctuates so rapidly, it's hard to determine which treatment approaches have been the best because it's hard to track. Moving on to discuss some of the main limitations of the current approaches, which are largely the generalized approach that we have and the inconsistent outcomes that arrive due to that generalized approach. The fatigue can often persist despite completion of rehab. These patients are graduating through rehab, meeting their treatment goals, and then they continue to report the need for breaks. They continue to report reduced occupational performance, reductions in quality of life well after graduating from therapy. And they have an ongoing need to restrict their activities or need for increased breaks, and outright sometimes have to withdraw from or never return to some levels of performance with some activities or ADLs just because they don't have the capacities to complete them. And the functional gains don't consistently translate to these outcomes. So don't consistently translate to reduced fatigue or sustained participation, improved engagement, and occupational performance. It's just as we see, they continue to need these breaks, they continue to have this fatigue, and it's persistent, it's relentless, and our treatment methods are too generalized currently to truthfully address it. There is a limited link between the brain functions and the fatigue experience. There's a limited link between the brain function and our treatment selection. We often conceptualize fatigue solely as energy depletion, deconditioning, or seen as a secondary symptom entirely, not something to be addressed, but something to be dealt with. And this doesn't account for the high effort with minimal impairment that patients have, the context and task-dependent fatigue or crash, and the unpredictable nature of the symptom patterns. So currently, the biggest gaps, or the main gap in OT treatment for post-stroke fatigue and our ability or capacity to effectively treat post-stroke fatigue can be summed up under a limited understanding, limited mechanistic framing in occupational therapy literature, and a lack of post-stroke fatigue specific OT treatment. And you can see that these things really compound upon each other. The limitations in our understanding limit our ability to put forth a mechanistic framework in occupational therapy literature so that we can then develop and test PSF specific OT treatments, which is really the goal of this lecture, to increase our understanding so that we can put forth the framework so that we can start testing PSF specific OT treatment, so that we can start attacking this thing at its core and reduce fatigue instead of increasing the capacities to handle fatigue as it continues to compound, because post-stroke fatigue is something that continues to compound upon itself day after day. And we'll get into that a little bit more in the next section when we get into the neurophysiology. But I just wanted to kind of get that painted right now and see that at its core, our gap in treatment for post-stroke fatigue is our limited understanding of what is going on. And from there, we cannot develop a research question, and we cannot make treatments and test treatments so that we know objectively that this will help. So now that we have a good understanding of what post-stroke fatigue is, its impact on the patient, and how occupational therapy and rehab services have been kind of addressing it and seeing it, we'll get into the current neurophysiology and really understand these mechanisms that underlie post-stroke fatigue and occupational performance deficits in these patients, with the goal of being able to really understand what's going on so that later we'll be able to target, whether through screening and treatment, to really start addressing post-stroke fatigue at its core. And we'll begin this section with a brief anatomy and physiology spotlight, going over the key areas of interest and areas that have been shown to be impaired in post-stroke fatigue in some current research. It's going to be the prefrontal circuitry, or CEO, our problem solver, our task completer, the occipital temporal network, that which gives meaning to what we're doing, connecting what we're seeing, feeling, and the actions we're making with memories and giving it purpose, meaning, and the frontal striatal thalamic circuitry, the striatum, thalamus, basal ganglia. This is a filter that kind of connects everything that's going on, helps us understand what is important to the task at hand and what can kind of be automated going on later. Going on and help with later, or can rise to important maybe. And it's the balance between the flow of this energy between the CEO and everything else, and the impairments in like circuitry and connections between these areas that is really starting to come to light in the research as the crux of post-stroke fatigue, and really the understanding of its context dependence. One of the first things covered in the research, and where we'll start, is with altered functional connectivity. Now this happens at the cellular level. This is between neuron and neuron. This is base physiological connection. And this altered functional connectivity is seen as a disruption of coordination and communication between brain regions and networks over time. With healthy and efficient function, this supports synchronized activity across regions, enables efficient information transfer, and facilitates integration across systems. It allows balance of signaling so that things can get done. In post-stroke fatigue, there is reduced or inconsistent connectivity between regions. This connection leads to less stable coordination across networks, and increased reliance on distributed, less integrated processing, which is meaning that pre-stroke, there is specialized pathways for certain things, specifically senses. And afterwards, due to damage, impairment, underperformance, it is forced to work on wider distributed, less specialized networks than the one that is damaged. Well, that will depend kind of on the where the stroke occurred, if it directly impaired the circuitry or if it's kind of like the collateral damage, some level of impairment is going to be is seen there. So we see slower information processing, difficulty coordinating cognitive and motor demands, and increased effort with tasks requiring this level of integration. And we know that this functional connectivity impairment exists thanks to some of this evidence-based research that we'll get into. We have two studies here for you. We have Cotter et al. 2021 and Wren et al. 2024, both of which looked at resting state functional connectivity in stroke patients. Cotter looked at chronic stroke comparing fatigue versus non-fatigue groups. And they used resting state neuroimaging and functional MRI and connectivity analyses. What they found was there was altered resting state activity in patients with post-stroke fatigue. And this was seen as frontal hyperactivity, so that prefrontal cortex, our CEO, is overworking, and posterior hypoactivity. So things towards the back are underperforming. So in this balance between front and back, the prefrontal cortex and our CEO is overworking, overthinking. And there's wider spread disrupted functional connectivity throughout the frontal and occipital temporal regions. So what we're doing plus the meaning of it going back and forth. And then there's evidence of greater distributed network disruption. And so Wren et al., they looked at the same thing, resting state function connectivity with functional MRI, but they looked at a specific region, a region known as the default mode network, which we will get into a bit more specifically later. But right now, as its name suggests, the default mode network is associated with or in control of keeping things automated. Anything that isn't directly relevant for conscious awareness or executive function in task completion is automated by the default mode network. This is heart rate, breathing rate, hair growth, anything that isn't important right now is automated so that the executive can be free to deal with the incoming information that's important for task completion. So then how is this cellular level connectivity imbalance presented at higher levels? First, we'll look at some sensory processes that we have. The first one being sensory reweighting. This is the dynamic prioritization of sensory input based on reliability. This is how we balance visual, proprioceptive, and vestibular information, as well as everything else, typically focused towards the exteroceptive information. For example, if you're leaving a movie theater after being in a movie for a long time, say you saw Lord of the Rings, Two Towers, the extended version, because it's one of the best movies ever made, and you leave that theater, the sun hits your eyes, everything goes white, you can't see, and you shift from visual dominance to a proprioceptive and vestibular dominance so that you can maintain upright position, not fall, and continue the task of walking back to your car. This is that process. In post-stroke fatigue, this process has been seen to be impacted and impaired. There's a reduced ability to prioritize reliable input. There's an increased reliance on inconsistent and internal signals, which we'll get into that a little bit more later as well, the internal signals. But the information coming in, they have a difficulty prioritizing what is important. And we see this clinically as a visual dominance. They are starting to need to have direct vision to complete tasks because they can't rely on proprioceptive and vestibular anymore as much as they used to. And this is at a greater level, we see difficulty managing complex environments, reduced tolerance to multitasking, increased performance variability, impaired postural control and gait because sensory reweighting is directly controlled to maintaining our posture, and reduced stability in general. This leads to partially an increased fall risk because it makes navigating environments difficult. It makes standing more difficult and more taxing. The next sensory processing capacity or the impairment that we'll be looking at is called sensory attenuation. Sensory attenuation is the brain's ability to downweight predictable, self-generated sensory input. One of the simplest ways I can explain it, because sensory attenuation is its own big thing, and we're really looking at both sensory reweighting and sensory attenuation in the context of task completion in this presentation. But with sensory attenuation, it's the reason why you cannot tickle yourself. It is an expected, self-generated feeling. So when you try to tickle yourself, it's already been attenuated or suppressed. In healthy function, it suppresses expected sensory signal. That is that tickling suppression. It reduces unnecessary processing load by removing things that aren't necessary for task completion from cognitive awareness or direct executive function in task completion. And it allows focus on novel, relevant input. It allows you to adapt to the changing environment because that's what's relevant to the task. In post-stroke fatigue, there was reduced suppression of predictable input, so there is an increase in weighting of self-generated input, which oftentimes leads to it being processed as externally generated input, overloading the sensory reweighting that is already impaired. But with sensory attenuation, the overall processing of there's an over processing of routine sensory information. This is what is typically attenuated or typically set to the default being risen to the executive because it can no longer be efficiently suppressed. Clinically, we see routine tasks feeling disproportionately effortful, heightened awareness of movement or internal states, and early fatigue during sustained activity. So sensory attenuation, while it might be an overstep in the context of this lecture, sensory attenuation is the main mechanism, in my opinion, for the increased perceived effort that patients with post-stroke fatigue usually report. That brushing their teeth has become too much. That just they were watching a movie and it took it out of them. They're over-processing internal states, which doesn't really allow their brain to rest. Another process that has been shown to be altered in those with post-stroke fatigue is motor programming, seen as altered cortical spinal excitability. This is really sensory motor integration before that signal is sent out. This is an impairment in responsiveness of motor pathways that regulate voluntary movement. In healthy and efficient function, there's optimized motor unit recruitment, enables smooth, efficient movement, and matches output to task demand. With healthy movement and task initiation, motor programming, immediately before the cortical spinal tract sends its signal out, there is a profound silencing or attenuating of sensory information so that signal goes out clearly. And in post-stroke fatigue, we see that there's altered or reduced excitability of motor pathways, meaning this is either too difficult to get that signal out, or there's an increased level of signaling or excitability in these regions right up until the moment of the signal getting out, which means that the motor cortex, is still analyzing movement up until the very last second before it goes out. Which leads to an increased noise, a weakening of that signal, or an inability of it to get through all the way, which leads to some of the motor performance impairments that we see in stroke survivors. But all of this is happening before that even gets out. So there's inefficient recruitment of motor units, greater neural drive required to produce the movement, and reduced inhibition of premotor signals. That is that up until the last moment, thinking about what needs to be done, trying to make sense of the sensory information, whether it does or does not really relate to the task. It is getting in the way of the motor signal being sent out. And clinically, what we see is the movement feels more effortful despite preserved strength, reduced endurance for physical activity, and an early onset of physical fatigue, which contributes to that early task termination or the need for more breaks. This impairment in cortical spinal excitability was found for us in this study by Donker et al. In 2020. The population was stroke survivors with minimal impairment, and he characterized them by high versus low fatigue. In this study, what they did is they had an auditory reaction time task with a warned versus unwarned condition, which they were having the patients with the EMG connected to their first dorsal interosseous, so they're just abducting the index finger when given the cue. And then they had the warn task, meaning there was a cue given to warn of the actual initiation cue coming. There was a ballistic finger response. They had TMS applied multiple points so they can get it. And they measured cortical spinal excitability and reaction time. What they found, though, was that there was reduced preparatory inhibition with higher fatigue. So the higher fatigue, the more cortical spinal activity was seen up until the movement initiation. And then increased pre-movement facilitation closer to movement onset, meaning they were still thinking of it up until the movement. Slower reaction times when preparation time is available, so those in the warned condition still had impaired reaction times given warning, and that altered excitability correlated with fatigue severity. So the higher the fatigue, the greater the excitability, the altered excitability, which means the worse the reaction times, potentially giving us a way to measure fatigue's impact on task initiation through reaction times. But what it did give us, for sure, in its findings was that there's less efficient motor preparation, there's increased effort and time required before movement, and that there is a breakdown in predictive processing, which is seen as the impaired reaction times. So to try and illustrate the impact of these underlying neural mechanisms and sensory processing impairments, impact on task performance in those with post-stroke fatigue, I have these two little diagrams for you. On the left, there is kind of a mechanistic breakdown of what is going on at that processing level. Impaired sensory reweighting compounding with reduced sensory attenuation. As I had said, due to the reduced sensory attenuation and the increased conscious awareness of internal body states, those internal signals start to be processed as external or exteroceptive information. So then sensory reweighting, which is the process that is already impaired at that cellular level, is then overloaded. And this combines in its own kind of dastardly little cycle, which also has one of its motor impairments being predictive processing impairments. It leads to increased correction, slower execution, increased computational cost, while the cortex tries to handle this increased sensory processing, and we see its impact on cortical spinal excitability. You see the physiological computational cost in this increased excitability, and I mean the increased computational cost of these impaired sensory processing impairments. And this culminates in that loss of automaticity that require the need for conscious control to do this processing. And from a task performance side, the image on the right is kind of just a breakdown of what is typically all the information that is processed, all the sensory information that is processed to get a motor plan ready, clean, and out to complete a task. There are multiple stops it needs to go to. There are multiple things that need to be done, and this processing is usually done before a motor plan gets out. And in those with post-stroke fatigue, what we have seen is that it is going on up into the very last minute, which leads to the increased level of fatigue. A, through the increased literal computational cost of getting this done, and then due to the reduced sensory attenuation and the increased conscious perception of internal states, patients are more aware of the physical cost of getting things done, whether it's the same thing they used to do. You can think of it as the limbs being louder. Even if you're grabbing something heavy and now you're more aware of how heavy that is in comparison, that requires more processing. That requires more computational cost. That requires more energy. All of which is consistently happening because these impairments are seen at the baseline. So this is why rest doesn't improve post-stroke fatigue. They are consistently working with less and less because their brain is consistently working just to maintain basic performance. And by basic performance, that can be sitting and watching TV. Is now costing them energy when it used to not. So I know that was a lot of information coming at you at once. And while that is a lot of information, luckily it can kind of be, as from a performance aspect, it can be summed rather simply as neural inefficiency. So with healthy function, we see coordinated activity across neural systems, prioritization of relevant sensory input, suppression of what is predictable or irrelevant. What can be automated is automated, and things are done with the minimal effort needed to get them done, maintaining and saving or preserving output for when we need it most. In post-stroke fatigue, that coordination is reduced. There is increased processing of the internal states or just irrelevant information. So there's more noise, signals aren't suppressed, there's more noise, there's more computational cost of getting things done. There's a greater reliance on controlled, effortful processing, meaning that the executive is in charge. You are constantly aware of internally what's going on, externally what's going on, and just how much needs to be done and how much it's taking out of your body with that reduced sensory attenuation, increasing your perception of your internal state. So you're more aware of how tired you are. and there is an increase of resource used for the same output. So again, as I said prior, back in the approaches of occupational therapy, when we were talking about energy conservation, prioritization, planning, and pacing, how many spoons are they going to parse it out into? How many cups can they pour their water into? And I said that each time they pour that water out, it is less and less and less. And we have taught them to sparse out less and less and less. Because from our perspective, how we treat things, that rest should be improving it. That water should be getting more and more full. And in these patients, it simply isn't. And it is due to this inefficiency. At the cellular level, it is impaired, which what we expect post-stroke, specifically in the acute phase. Of course there's going to be a neural inefficiency. And the point, and when we treat these patients, we build them and give them the skills to maintain performance, and hoping that it's going to build over time. And I think I've harped on it a bunch already, but that's simply not going to happen with the blanket way we address post-stroke fatigue. And we need to start addressing it based on these underlying neural mechanisms, because they can be targeted and they can be treated to help improve and actually reduce post-stroke fatigue instead of teaching people how to manage it. So if you start interpreting post-stroke fatigue through this neural efficiency lens, you take common presentations like our case scenario Marcus from earlier. The ambiguity of post-stroke fatigue, or at least where it arises, the context-dependent nature and the rapid fluctuation of it, starts to make a little more sense. So we have tasks that were once automatic now require active, effortful processing. And this is due to just altered functional connectivity. Due to that and that resting state hyperactivity in the frontal and the prefrontal cortex in that region, and the posterior hypoactivity, that imbalance from resting, post-stroke fatigue patients are using more energy just to complete a task because the frontal region of the brain is working harder at a base cellular level. And due to that impaired connectivity, we have difficulty managing multiple inputs, which reflects reduced signal prioritization, which is our impaired sensory reweighting. They are less able to prioritize the information coming in because of the functional deficits in the networks for sensory reweighting. Similarly, with sensory attenuation, routine activity feels effortful due to increased internal processing load. They have a reduced ability to suppress internally generated signals, which are then filtered and processed like external stimuli, putting more pressure on the sensory reweighting system, which is already impaired. And then the fatigue emerges as demand exceeds an inefficient processing system. It's not random, it's not out of nowhere. The system can no longer process effectively, so it has to stop. It forces reduction of performance or complete termination of the task because it simply can't do it anymore. So now that we made our way through the physiology, what's going on at the processing level, at the cellular level, now we're going to take a look at some of the emerging neuroscience of post-stroke fatigue and move from the individual neural processes to a large-scale network coordination. So how does neural inefficiency connect to network coordination, and how are they related and work with each other? So performance depends on coordinated activity across large-scale networks. It is required for daily functioning to get everything going, organized, processed, and into a specific coherent code for any level of task performance, even if it's just maintaining upright positioning while sitting. And as these processing becomes less efficient, the demands increase on the network coordination and the neural networks themselves. For example, earlier I mentioned that after a stroke, and we know that these specialized pathways, these specialized systems typically are, if they're injured, non-specialized, more widely dispersed systems or pathways have to be used until that one is repaired or something better or efficient enough is restored. But neural inefficiency is not isolated to a single process. So it's not just sensory attenuation, it's not just predictive processing, it's not just sensory reweighting. It is widespread, and with post-stroke fatigue, the neural inefficiency is widespread in these greater systems. The system we'll go over in the next slide. But multiple systems are needed to coordinate and allocate attention, regulate effort, and transition between tasks. In order to effectively navigate through our day, efficiency and network coordination needs to be like top tier, or at least unimpeded, for efficient, safe, high occupational performance. So the neural network model, or the neural network that I will be referencing in these lecture series and using, is the triple network model. The triple network model was introduced by Menon in 2011 and again in 2019 as a way to understand the behaviors and processing in neurological conditions and psychosocial and psychological conditions as well. In 2019, the study focused on being able to use this network model as a way of understanding the pathophysiology of what is going on in these conditions. So in the triple network model, there is the central executive, the salience, and the default mode network. Similarly to the areas identified at the beginning of the neurophysiology section of this lecture, the executive network is that prefrontal cortex. In that area, it is focused on task-focused processing, attention, working memory, motor control, control of the task, problem solving. And that default mode network is everything that is not relevant to the task at hand, things that can be the internal processing, baseline, automatic activity, things that aren't relevant to the task that we are doing, but are relevant to maintaining homeostasis in the greater task of living, regulated by the default mode network. And the salience network is what determines and switches between the two. It detects relevant internal and external signals and determines what's important enough for the executive function, for the executive network, what is relevant to task completion, and what can be automated, what can be set to baseline and internally processed. And in this switching is where we see the impact of impaired sensory reweighting and sensory attenuation. The body has difficulty determining what's relevant from the external signals, and on top of that has the increased perception of internal signals, making it difficult to determine what needs to be in the executive network, what is relevant for task completion, and what can be automated in the default mode. And since the default mode, we know from the imbalance, we have in the posterior hypofunctioning in the areas where the default mode network typically where the default mode network is, everything is just being sent up to the executive, because from a physiological level with the impaired connectivity, the default mode network cannot effectively run. It cannot maintain things at baseline at automaticity due to the underperformance of those cells and the impaired functional connectivity in that region. And it is the continuous filtering through these three networks, essentially, where performance in general, task performance, task completion, but occupational performance truly lies within this model, and the balance and the flow between these regions. One of the largest similarities or arguments for applying this triple network model to post-stroke fatigue is that these areas, the network, salient, central executive, and default mode network, coincide with areas that we know to be impaired directly in post-stroke fatigue. The prefrontal regions, the frontal striatothalamic circuits, and the occipital temporal networks. Everywhere that there has been measured, proven impairments in post-stroke fatigue patients in the sensory processing and the areas of this region coincide perfectly with not only the anatomical regions of the triple network model, but the functions of the triple network model as well. So this is why I have chosen to apply this to post-stroke fatigue when it comes to performance. So while I discussed it a bit on that last slide, I have the dysfunction in the triple network model and how it relates to post-stroke fatigue and the presentations and the impact that it has. Just kind of written down here simply and shortly, at a systems level, there's inefficient switching between networks. That is reduced capacity of the salience network to determine what is relevant and effectively determine what can be automated and what needs to go up to the executive network for direct control. There's increased costs of maintaining task engagement. That is that greater reliance on controlled processing and greater activity within the central executive network. And then reduced ability to regulate effort. That comes from the impairments in the default mode network and sensory attenuation, since it is in charge of those internal states and keeping those suppressed. Lack of ability to suppress those internal states makes the patient more aware of the work the muscle is doing. The muscle isn't necessarily doing more work, they're just simply more aware of it. And then as coordination across these networks becomes less efficient, the cost of maintaining performance increases. Just more noise, more cognitive load to get those computational processes done, to get motor planning, task initiation, and everything going. Just costs more to do the same as they used to, or in many cases, to do less than they used to. So now, to apply this network coordination model or perspective to post-stroke fatigue, we'll use Marcus, our patient from earlier. And in this thing, we're really looking at how inefficient coordination leads to breakdown in tasks. So when the task begins, it's manageable, but it becomes more difficult to sustain over time as we have to adapt, as things become more difficult, as the environment starts to play a bigger role, or as we become more aware of our internal environment. This increased effort is required to maintain focus and task engagement. This is the switching into the executive. The executive starts to take control as more and more control and become more and more taxed due to this impaired coordination as the activity is sustained, as we do it for longer. And you'll see there's difficulty shifting between tasks and managing competing demands, partially due to those sensory reweighting impairments. There's more and more external information that we are being bombarded with. Sensory reweighting systems are being bombarded as well. And so they are, from a functional level, inefficient in coordinating this information, and therefore the central executive has to seize control of it. And then there's rapid escalation of fatigue with continued activity or interruption of the task, and that is largely the impairment in sensory attenuation. They are less able to suppress what's expected and what's they're predicted of the input and self-generated input, self-generated stimuli, that they're just more aware of what is going on. So every time they miss a button, every time they reach for their water bottle, every time they do something, they are more aware of what's going on, let's say at the musculoskeletal level. So it requires more energy, one, to compute and process that sensory information, and then two, you start to feel, they perceive that as fatigue. Like, oh, I can really feel how much my muscles, I must be tired. So as a result, we see reduced endurance, activity-dependent crashes, and a withdrawal from more complex roles because they require too much computational processing and demand. To finish up this lecture one, now we'll start talking about translating some of the neuroscience to performance deficits. While we've gone over that, it kind of throughout the way, it's a good way to wrap it up and really understand post-stroke fatigue through this neural inefficiency and network breakdown lens. Just really trying to drive that home. If you take what we've gone over today, the neurophysiology, the network neuroscience, and start translating that to performance deficits, the underlying patterns for the performance patterns that we see they become clear. The reduced task endurance, the decreased tolerance for complexity, the increase in perceived effort, and the inconsistent performance are driven by increased neural and cognitive resource demand. To get things done, to be able to physically complete the task, and to organize the task, plan the task, get it done from a cognitive level or a metacognitive level, all of that requires much more energy. Literal metabolic cost, computational cost. That is seen and represented in that imbalance between the frontal and the posterior part of the brain with that hyperactivity. Our prefrontal cortex, our central executive, the part of our brain in charge of getting things done, is fighting for resources with everything else. It is honestly taking everything because it needs to do more. It has to, because the rest of the brain, the rest of the networks, can't do the things that they were doing efficiently. And since they're with that reduced efficiency, it affects the coordination of task performance. Because since everything is being held into the central executive network, since we're actively processing everything that's coming through here with a cognitive lens instead of anything being automatic or automated, this is a resource issue. We see in these patients that performance is preserved in capacity but limited in sustainability and efficiency or consistency. That is, in one session they are doing everything. Their strength is fine, they complete the task fine, and then in the next there's nothing, or the second they leave their task for the day. That fluctuation comes from the impairment in effective resource allocation, more so than their capacity, their strength capacity, their endurance capacity, or their cognitive capacity to actually organize a task. What really helped me interpret the role and the function of the triple network model and network neuroscience in general, and how that works with navigating and operationalizing occupational performance and performance in general in the human organism, was really using our cognitive hierarchy and our hierarchy of learning through development and understanding what's going on. I have it color coded, so you can see on the left we have our systems. On the blue is our default mode network. That red line is our salience network, and the green is the central executive. This is in a, this would say, for example, this would be in a non-stroke patient, typical functioning. What you have is the majority of things that can be automated, from base arousal in like proprioception and vestibular systems, body awareness or body schema, as well as eye-hand coordination, language, visual spatial perception, all of that really being regulated under the default mode network, except for the parts that are necessary for task performance. So for example, when we have on here reflex maturity or reflexive and attention, that is in, let's say, eye-hand coordination or ocular motor control, that is maintaining our eyes and focus on what we need to read instead of being distracted by something in our periphery. And this is kind of the distribution goes. The central executive network is focused on what needs to be done, what is relevant to the task, and the default mode is in charge of everything else, with the salience network determining what is necessary for the task and upweighting it as it sees fit or as necessary for a safe, efficient, and effective task completion. And so in comparison to what we see in the post-stroke fatigue brain or in the post-stroke fatigue patient is an imbalance of this. And you can see the central executive network in this exaggerated image has taken over conscious awareness of much, much more. And the default mode network has significantly shrink or smaller in comparison to what it was. And this type of imbalance is what really underpins and underlies post-stroke fatigue, as there is too much in the cognitive and there is too much of a difficulty determining what needs to go where. And so the brain just defaults to shoving everything up into the central executive network and making the patient more aware of what's going on so that it feels more in control of what's going on. And this leads to actual increased effort, increased computational cost, metabolic cost of existing from a neurological standpoint, and then increased perceived effort and the feeling that things are taking more energy than they are. So it is a balance between actual more energy being necessary and needed to maintain basic function and the feeling that things are taking more energy. And this cycle, this cyclic relationship just impedes performance at best, keeping them where they are at an underperforming, not back to the level of performance that they were, and at worst, a cycle that is continuously getting worse and worse and worse and never improving. So the key takeaways from today is that post-stroke fatigue is underpinned by neural inefficiency, impaired connectivity and processing at a local level, which compounds to then have widespread network level impairment seen as reduced efficiency of coordination between these systems. And as a result, there's a higher cost to initiate, sustain, and regulate performance. Basic living, basic existence become much more taxing than it was before. And that happens at rest and mostly and most, I should say, drastically during sustained task performance. So when working with patients with post-stroke fatigue, what I want you to consider is how performance changes with demand, where network inefficiency is occurring, and where the performance breakdown occurs. Is it when tasks become too complex, when conditions become too unpredictable, or when there's too many competing demands for them to effectively process and make a motor plan in general? So to close out this lecture 1 with just some closing thoughts, post-stroke fatigue is best understood as a disorder of neural efficiency rather than simply fatigue. Neural mechanisms provide a foundation for explaining the diverse presentation of post-stroke fatigue, and understanding these mechanisms is the first step towards understanding the condition itself, so that we can address the gaps in our treatment, improving our understanding, being able to take a mechanistic base when it comes to our literature and research, and finally being able to create some post-stroke fatigue specific interventions for occupational therapy. To help us move towards that goal, on the next lecture we'll take a deeper look at the sensory processing impairments and their role in occupational performance.